Hello. Hello, Catherine.
Hi, Masaina. How are you? All right, then. Thanks. I can see many Kabores. Welcome to all the Kabores. Is it one big clan?
Okay. Thank you. It's Catherine. Is Catherine? Hello, Catherine.
Okay, so we'll be starting in 3 minutes time. William, could you disable your video?
You see me? Yes, I
can see you.
can see me. Okay.
You. Welcome.
Thank you.
I was laughing. I was saying I'm seeing many Kabores. It's one clan, huh?
Yes, but I am the dean.
Ah.
So you can also call me Kabore. The others is Lasane and the other name and the name.
Welcome, welcome.
Thank
you. So
you.
we'll be starting in 2 minutes time.
Yes.
Great, it's 4 o'clock on the dot, Central African time. And I'd like to say hello to everybody, a warm welcome to all of you to today's Speed Learning Network webinar entitled Challenges in Ascertaining Proof of Vaccination in Routine Childhood Immunization in Burkina Faso. A special welcome to our speaker for the day, Dr. Lassane Kabore. My name is Catherine Muyawala, the Big Learning Network Coordinator, and I'm your moderator for today. And I'm really glad that you're able to join us. But before we get started, I would like to share some housekeeping guidelines. You have a little chat box on your right where would really appreciate you typing your name and the country where you're connecting from. And it would also be very useful if you could let us know if there are more than one person sharing the same connection. I mean, that is to say, if there are a number of you in the same room connected to one PC. or laptop. We would really appreciate that. Secondly, all participants will be muted, and this is obviously to allow the speaker to present without interruption. And we're kindly requesting that the videos are also disabled so that we don't compromise other people's bandwidth. Also to let you know that there'll be a question and answer session at the end of the presentation. And we're requesting participants to type in, to feel free and type any questions that they may have for the presenter in the chat box. And these will be logged and answered during the question and answer session. Also be advised that the webinar will be recorded, and we'll definitely share the recording and the slides via the BID website. So this webinar is actually being hosted by the BID Learning Network, which bridges countries and regional as well as global partners that may be interested in strengthening their health data management systems. And this is normally done through mentorship, peer learning, capacity building, advisory services, and knowledge management. And the target audience normally for the BLN webinars are policymakers, well, not limited to them, funders, EPI managers, health management information system specialists, data management specialists, and any other healthcare specialists who are committed to improving data management across the health systems. So in today's webinar, our speaker will be sharing with us the key findings from the lessons learned from a 6-week cross-sectional survey that was conducted in 30 health facilities in 10 districts of Burkina Faso. The whole idea was to interrogate inconsistencies between primary vaccination recording tools. And our special guest who will be walking us through the presentation today is Dr. Lassane Kabore. Dr. Lassane Kabore, welcome once again. Dr. Kabore is currently Senior Program Officer with Path Center for Vaccine Innovation and Access, and he's currently based in Lusaka, Zambia. He is actually charged with responsibilities for the southern region for this particular project. And some of his responsibilities include, representing and serving as primary liaison with EPI staff and relevant global immunization stakeholders within the Southern African region. He also contributes to planning, developing, and implementing programs to improve vaccine use, and also to increase vaccine coverage, and also to assure equitable distribution of vaccines within the region. He also serves and contributes as a subject matter specialist or expert in vaccine preventable diseases and vaccinology, new vaccine introductions, and post-licensure clinical studies, and these pertaining to vaccine effectiveness, impact, and safety. And prior to joining PATH, Dr. Kabore worked with the Agence de Médecine Préventive as coordinator, epidemiologist, and investigator on various research projects and technical assistant projects. And earlier to that, he worked at the Ministry of Health in Burkina Faso at both national and sub-national levels. So we also know that Dr. Kabore has got a very rich, academic credentials. He holds a doctorate in pharmacy from the University of Ouagadougou in Burkina Faso. He also has a joint Master of Science in International Health from Berlin and Bordeaux universities. This is in Germany and France, respectively. He also holds a Master of Science in Public Health in Epidemiology, obtained as a Fulbright Scholar at the University of Alabama in Birmingham. in the USA. And he is really busy. He's currently finalizing a part-time doctorate in global health at the University of Geneva in Switzerland. And something else that you should know, he is fluent in both English and French. So he is bilingual. That's a very rich CV. So we know that there's a lot that Dr. Kabore will be sharing with us. So Dr. Kabore, welcome to this webinar, and may I invite you to take. Can I stop sharing so that you share your screen?
Sure.
Thank you.
Can you see my screen?
Yes, perfectly.
Okay. So thank you, Catherine, and good morning, good afternoon, good evening to all those who were able to join this this webinar. It's my pleasure to take you through this study that we had conducted in Burkina Faso and related to the challenges that one might face in ascertaining proof of vaccination in a routine childhood immunization. I should say this presentation is based on an article that we co-authored recently in the journal Vaccine. I would encourage those who have a particular interest to try to read the full paper. And you can see the other team members that were part of this, this work, and I hope and guess some of them are also attending this, this webinar. Quickly, this is the outline of the presentation, a quick background, some information and the methods, the results that we want to share with you, the conclusions, and then the lessons learned. We will end up with some recommendations and some acknowledgement. So Burkina Faso has recently introduced several new vaccines into the routine immunization program. When I say recently, it's relative, but those vaccines are among the latest to be introduced in the country. For instance, you had rotavirus and pneumococcal conjugate vaccine in 2013, measles rubella, the second dose in 2015, serogroup A meningococcal conjugate vaccine in 2017, and inactivated polio vaccine, as far as I know, was the last to be introduced in 2018. So there was a lot going in the country regarding new vaccine introduction, and which is good. But at the same time, it should be an opportunity to update vaccination recording forms, because at the end of the day, every child that is vaccinated will need to be recorded on those forms, which include health facility-based record, also known as immunization registers, or the home-based records. Some people call them vaccination cards. So both are valuable data sources because if you want to know the vaccination status of a given child or a given person, only in those documents can you go to find out what information is there. So they will be useful for service delivery and also for program performance review. For instance, when you are conducting a coverage survey, we'll go there to look for the information. So which means that they are really very important. And in the scientific community, if you interrogate the literature, you will find out home-based record, particularly vaccination cards. They are increasingly the focus of field research, and the previous studies that we have had the opportunity to consult investigated their characteristics, their availability, and their value in determining vaccination status. But little is known about those two types of documents in low-income settings with frequent new vaccine introduction. In the specific case of Burkina Faso, where we were personally responsible for certain epidemiological studies, our field observations and some anecdotal report had indicated an important diversity of circulating home-based records. And as new vaccines are introduced, those two types of documents, they need to be updated accordingly, timely, and also at the countrywide. If this is not done, we might end up in having some challenges when the time comes to assess the vaccination status for a community or a subgroup that have been vaccinated. And the administrative coverage, most of people know that administrative coverage is what is routinely reported to assess immunization performance, but this metric is prone to numerator and denominator biases. So you can't always rely on them, and sometimes you might need to conduct a survey or a formal assessment, and that's the time we will face the realities that home-based record or facility-based record may not give you the right information. So in this study, we assessed the characteristics of the home and facility-based record, the completion or their feeling by vaccinators, and their usefulness in estimating vaccine coverage for individual antigen or for like a full proportion of fully immunized children. About the study setting, as Catherine has alluded to earlier, this was done in Burkina Faso. As you can see on your left, this is a map of Africa that I took from, actually a map of the world that I took from Wikipedia. You can see Burkina Faso somewhere in the middle of West Africa in green. It's a landlocked country with approximately 20 million inhabitants. And on your right, you will see the 10 health districts that were taken from 70 districts in the country. And those are the districts where this assessment was conducted. The design itself was a cross-sectional study based on a questionnaire that were completed in those 10 health districts. And I should say that those 10 health districts were having suboptimal performance and were selected to be supported by the Ministry of Health and other partners like Agence de Médecine Préventive as part of the Global Health Security Agenda Initiative. And within each health facility, we had selected within each health district, we had selected 3 health facilities based on the convenience sampling to align with the field realities. And the 20 caregivers were also expected to be interviewed in each health facility. And we stratified that so that we could have 15 caregivers of children aged less than 1 year and 5 caregivers of children aged 1 to 2 years. Without this stratification, if you just want to take the children as they come out of the health facilities, you may end up with very, very few children aged 12 to 23 months, and which will somehow bias the sample. So as already said, the questionnaires were used to collect data, which included socio-demographic of the caregiver and also of the child. We also collect information of the characteristics of the home-based records after examining them and to see, for instance, what is the number of vaccines that the card displays and what are the names of those vaccines. If some vaccine had already been received, we captured the dates of those vaccinations and also captured the information on the same vaccination from the health facility register. And we also collected history of vaccination on not on all vaccines, but on pneumococcal and PCV and rotavirus vaccine. Our thinking was that given the particularities that we see in the administration of those vaccines, for instance, PCV is given at the same time as the pentavalent vaccine. So the children usually receive 2 injections at a time, which is like a landmark for mothers to remember. And the rotavirus vaccine was also like a drinkable liquid that is given separately. So we thought that those clues would help mothers to remember them. And the other information that we collected included the characteristics of the health facilities and also of health facility registers. We were only able to take sample pictures to illustrate the main type of vaccination that we encountered. However, I should say that the current recommendation, especially from WHO, recommends the taking systematically pictures. So this was somehow a limitation of our investigation. So in terms of data analysis, we had to agree on certain operational definitions in order to be able to come with certain results. First, there's a standard home-based record. We defined that as one home-based record of one vaccination card that showed pre-printed recording fields for all the 17 vaccine doses of the routine schedule at the time of the study. And equally, a standard facility-based record was defined as the official and updated version of vaccination register supplied by the API Directorate of the Ministry of Health. And for fully immunized children, this was defined as children who had received all recommended vaccines in the schedule, which range from birth, like birth vaccine doses BCG and OPV0, through vaccines given at 9 to 11 months, Euro fever and measles rubella first dose. So as you can see, this definition was limited to children less than 1 year, which might be questionable, but we used that definition because it was the one used by the Ministry of Health at that time. And also discordance of information was defined as a situation where the information between the home-based record and the facility-based records were different, meaning that they were providing different information in terms of vaccination status, or even in the situation where one document was saying that the child was vaccinated and the other was saying the child was not, those were also considered as situation of discordance. So you can see that the number of discordance that you can observe in a given child was a discrete number that could range between 0 and 17, which was the number of vaccines a child could have received in total. So our analysis just first looked at descriptive statistics as usually done. I just spoke about discordance. So we use discordance as a proxy of data quality. And so we assess the relationships between discordance and potential predictors, variables using logistic regression. And then we also calculated those specific coverage for each of the 17 doses I just talked about of in the EPS schedule. We also calculated the proportion of fully immunized children using different sources of information. The idea is to do those calculations and see to how they compare to each other. Since we collect information on history of vaccination for PCV and rotavirus vaccine, for the reasons that I have already mentioned, we added that information in the assessment of fully immunized children to see how it affects the estimation. And we assess the agreement between home-based record and facilities-based records, taking the former, the cards as the gold standard. As you see, gold standard is put in bracket because none of the two types of documents is really perfect. But we took home-based record as the reference and then calculated the sensitivity, specificity, negative and positive predictive values, and the kappa statistics for the information given by the immunization register. We used Stata 13, version 13 for data, actual data analysis. So in terms of ethical consideration, this work was determined to be a non-research activity, but rather a program review. But it was approved by the Ministry of Health, and actual data collection and other activities were collected in close collaboration between Agence de Médecine Préventive and the EPI Directorate. However, we made sure that we obtained the verbal consents of the participants before interviews, and the final database contained no identifying information. So to our results now, we eventually recruited 619 children for an anticipated number of 600. You see three quarters of the children were aged less than 1 year, which is in conformity with our stratification to have such a proportion of children aged less than 1 year. Nearly half of the sample was female, so it was gender balanced, and 43% were from rural areas. As expected, most children, almost all children, 98% were taken to the vaccination by their mothers, and 53% of caregivers had no formal education in the study setting. The health facilities that were studied were all public, meaning that there were government health facilities. And the number of immunization staff ranged from 1 to 10, with a median of 3. All health facilities had registered to record vaccination data. However, when you look to the characteristics of those health facility registered, also known as facility-based record, we found that 2/3 were standard, and the other third was consisted of different adaptation from the standard version. In the absence of the standard version, I think in every health facilities, people try to be resourceful to proceed with immunization activities. So when I speak about non-standard facility-based records, you can see on this slide on the left, this is actually a notebook that has been adapted to capture vaccination data in the health facility. So this is a non-standard health facility-based record. On your left, you see those are tally sheets that vaccinators use daily to record vaccination information, and from the look, you can see that might be challenging to keep good information or to retrieve good information from those sources, those documents. In this slide, this is just some illustrative pictures of the different type of home-based record that we have seen. So on your top upper left corner, the image that you see, this is the standard home-based record. Ideally, that would have been the only type that we would have seen in the field, because based on our definition, it has recording field for all the 17 antigen, starting from BCG all the way through RR2, which is the measles rubella second dose. However, when you look to the right of the figure B, this is just a page of a school notebook that has been used to record vaccination information without any pre-printed item. You will see type C in the bottom left, which is one of the most frequent type of record immunization home-based record that we had seen at that time, you will see that it had information on DTC heavy. This is pentavalent. It had BCG and polio. Okay. Sure, this is MR, here shown yellow fever, but you will see that the recently introduced vaccine, PCV and rotavirus vaccine, and also MR2 were missing from that type of record. So to record vaccination on such a tool, either it requires dedication from the vaccinator to mention extra information, or the information will not be captured accurately. And the last image, image D, this is called in Burkina Faso Carnet de Santé, which is a curative consultation card that has been adapted to capture immunization information. And when we looked at the proportion of standard home-based record, as you can see here, nearly half of 51% of the 615 home-based records that were able to be assessed were considered standard, which means the other half was made of non-standard version of the card. That there was a huge variability of standard vaccination card across districts, ranging from 12% in the district of Po, which is in the southern part of the country, to up to nearly 81% in the district of Kaya, which is somewhere in a little bit in the northern part of the country. And then we tried to see what were the vaccine doses or the antigen that were mostly missing from the home-based records. So you can see that this also ranged from BCG, which only had 2% missing from vaccination records because it's an old vaccine and most of the home-based record would have it, up to MR2, where we had nearly 48% that did not have that antigen pre-printed. And as you can see, most of the antigen that were missing from those home-based records were the antigen that were recently introduced, PCV, rotavirus, and MR2, which is an indicator of the fact that the vaccination card had not been updated before or during the vaccine's introduction. And then we wanted to find out what might be the reasons of, we wanted to analyze or appreciate the recording of information. And we find out that in some instances, the information is not recorded in the vaccination card, even if the child has been vaccinated. So there were some information mismatch between the home-based record and the facility-based record. Facility-based record would say the child is vaccinated. Home-based record would not say anything, which means the child was not vaccinated. So when we look closer to this subgroup of children, then we found out that those children that didn't have information recorded after they had actually been vaccinated their card would not have pre-printed fields for those different vaccines. Like more than 80% of the cards in these children would not have pre-printed information for those different antigens. So which means that under reporting or under recording of information would occur primarily when the home-based record is updated and doesn't have data capture fields. In assessing the agreement between the two sources of information, there's a lot on this slide, but what is worth to note is that the median kappa, the third column, which is a metric for agreement between two pieces of information, we see that the median kappa value, which is 0.48, means that it's a moderate agreement between those two sources of information. Of course, it varies between It varies across the antigens that you are interested in, because it would be, for instance, 0.74 for yellow fever, which is an old vaccine. But when you look to certain other vaccines, let's say rotavirus, you have 0.65, or OPV2, you have 0.21. Anyway, there was this variation across the different antigen that you are looking at. What was also important to note is that the negative predictive value for the immunization register tended to be low for most antigen, which means that even when the immunization register tells that a child is not vaccinated, you need to double check with other sources, because it's likely that the child may have been vaccinated, but this information was missing from the immunization register. And I had previously talked about discordance of information. So you can see that nearly 2/3 of the children had discordant vaccination information between home-based record and facility-based record, meaning that discordance on at least one antigen out of the 17. And you can see that discordance was seen at an important proportion in almost every district, which means this is a problem everywhere. In terms of factors that could be associated with discordance of information, I didn't show the results for the univariate here, but I went straight and showed the variables that were included in the multivariate logistic regression, which included age group, standard home-based record, standard facility-based record, and timely completion of the home facility-based record. So we could see that age factor was risk factor, age group of being age less between 1 and 2 years was a risk factor. I say risk factor in bracket, as you can understand. This is not, I mean, we're not looking to a disease as such, but anyway, we are looking to a problem, so we can still speak in terms of risk factor with a significant odds ratio of 3.05. And conversely, you could see that having a standard home-based record, meaning that having a home-based record that was fit for data capture, was associated with lower risk of discordance. So this was protective with an odds ratio, a significant odds ratio of 0.46. Okay. Here you can see in this slide the average that we calculated for different vaccine doses, actually for all the vaccine doses, using different sources of information, home-based record, facilities, home-based record is in black, facility-based record in gray, and the combination of those two documents, this is what you see in light green. So the takeaway that we see from this graph is that coverage estimation by the cards was consistently higher than that of registers. But when you add the register to the card to accept vaccination status from either document, you see a slight improvement in the green. So, but we thought this improvement was modest for most of the vaccines. And then we did the same exercise of coverage calculation, but this time looking at the proportion of fully immunized children from different sources. You see here, home-based record is the first one, facilities-based record, and then the combination of both. And when you add recall in the last column, you see that adding recall substantially increases the proportion of fully immunized children. The difference between the gray and the black is that during the time of the survey, there was a stock out of yellow fever vaccine. So we thought if we wanted to calculate fully immunized children without taking the stock out into consideration, we might be underestimating actual coverage. So we did the calculation with both sources. But in any case, what is important to note is that if you add a facility-based record to home-based record, you gain a little bit, like something like 5% of additional people vaccinated. And then if you go further and add recall, then you have a much higher proportion of people vaccinated. The question of whether one should add recall or not is a different one, but I think it's a legitimate question in people involved in assessing immunization coverage. So in summary, for our results, quickly, we found that half of the home-based record and a third of facility-based record were outdated and therefore unfit for proper data capture of individual vaccination information. We also observed inconsistent completion of these forms by vaccinators. 1 in 6 facility-based record was not filled with the latest vaccination information, meaning that they were late in capturing information. And many vaccine doses were not recorded in the home-based record following actual vaccine administration. And those were the most recent vaccines introduced in the schedule that were mostly missing from the home-based record, and consequently they were often not captured even when the child was vaccinated. The agreement between the two documents varied across vaccine doses with a median of 0.48, which was a moderate agreement, and nearly 2/3 of the children were concerned with discordance of vaccination information between the two sources, and adding information obtained from caregivers recall increased the vaccination coverage estimate. In terms of lessons learned, there might be other lessons, maybe if go through the full manuscript and the discussion points and other elements that we talk about, one might see other lessons, but I would just wanted to mention a few here. The first one is that the quality of recording forms, be them facility-based or home-based record, will determine the quality of their filling by vaccinators. So you cannot assume they will manage. I remember one vaccinator telling us it's up to you at the central level to provide us with proper documents. We are not computers. We can't figure out things that have not been printed appropriately. And also the triangulation of information between home-based record and facility-based record may prove useful in the determination of vaccination status. As you could see, neither document was really perfect, but if you triangulate and you put the two together, you might gain some precision in terms of determining who is vaccinated or who is not. And also the precision of coverage that you will estimate will depend on the quality of the primary recording, because that's the information source. But the quality of that recording itself depends on the quality of the recording forms where the information is noted. And the patterns of primary recording, that's our understanding. The patterns of primary recording with vaccination information may be an overlooked area in immunization data quality improvement efforts. People may be looking at different aspects of data quality, etc. But at the end of the day, if you are not sure that each and every child that has been vaccinated has been recorded and that you can really trust those primary sources, then we'll still have challenges with data quality. In terms of recommendations, we try to stratify them in terms of short-term actions and long-term actions. So short-term, we thought of having participatory planning that would involve all stakeholders, including all people who have interest in home-based record, even the community members, and also the funding agencies who might support those initiatives. The regular redesign of and pre-testing those document, home-based record and facilities-based record, as routine schedule evolves. So whenever a new vaccine introduction is anticipated, then immunization managers should initiate some work in order to update those tools. And not only update them, but to ensure their continuous supply, because some of the forms that you've seen in the pictures, like the notebook pages that have been adapted, those situations happen because the official versions were out of stock and just people put their imagination into practice to find a local solution. So training and supportive supervision of health workers should also focus from time to time on those topics. And in implementation of job aids might also be relevant in the field. And also whenever people do like this type of assessment that we have done, whenever an assessment is done or monitoring is done, the results should be used to make action, to take action, make decision and improve the situation. And the longer term action that we see could involve the implementation of an electronic immunization registry. The reason why we thought this was a longer term action is because you can't start immunization registry overnight. You need some proper planning and make sure that when you start, you will not end up going back to paper-based records. In terms of recommendation, we also think that beyond Burkina Faso, the action that I just talked about might also be relevant for other countries in the region with similar context. And we encourage future research in this area to include systematic picture taking and assess other quality elements beyond vaccination recording fields. If you interrogate the literature, you will see that other people have analyzed different areas of the recording tools, not just the issue of recording fields. So to end up with the acknowledgement, I mentioned the Global Health Security Agenda, which provided a funding opportunity to conduct this assessment. Also, the Ministry of Health of Burkina Faso, the Agence de Médecine Préventive, where I used to work, the study support team and the study participant. On that, I thank everyone for your attention. I'm happy to take questions or contributions, and also, as time permits, some of the co-authors of the paper who might be in this call could also step in and address some of the comments. Thank you very much.
Thank you so much for that, Lassane. We've gotten to a stage where we're able to take some questions, and there were actually a number of questions which were queued, and these ones, well, I mean, quite a number. There was a question on were there any particular reasons why you focused on low performing districts only? Then the second question was on the caregivers. Somebody observed that the caregivers, with low or no education are actually associated with low vaccination coverage. How might this have skewed the study findings? And maybe we can also take in a third one. You can answer three. They're asking whether Burkina Faso is considering deploying any electronic immunization registry to remedy data quality issues. Are you able to answer these three questions, Lassane?
Sure. So yeah, I think those who asked those questions for the interest. For the first question, why we focus on low performing districts, I should say that As I just mentioned at the end of my presentation, the funding opportunity for this assessment was provided by the Global Health Security Agenda, which was being implemented in Burkina Faso on those particular 10 districts. And those were also chosen because of their poor performance. So it would have been difficult for us to extend the geographical scope of the study. However, I think we acknowledge in the paper that this might be a bias which might underestimate the actual picture of the situation in a country. But let's assume the situation is better in the 60 other districts. Then it means that we still have problem in at least 10 districts, and that still need to be addressed. The second question regarding the caregivers' law education, indeed, this has not been shown in this presentation, I think, but in the manuscript we show that there was association between caregivers' education and also being residing in rural areas. We didn't really dig deeper to find out what might be the actual explanations, but you can think that an educated mother, an educated caregiver is likely to be proactive and either ask herself for an appropriate card, or be able to find out difficulties and the recording that she has observed in the card. This might be an explanation among others. In rural areas as well, we really don't know whether it's coincidence because we didn't look to many factors, but we found that the most being in a rural area was a risk factor for not to have an updated or not to have concordant information that was of quality. Again, I will not speculate, but in any case, those results could be used to take action and specifically look closer and see why is it that in those areas we have that problem. Why is it that mothers of that are uneducated were also having this problem? But as we mentioned in the paper, this could lead to inequity in immunization, because if those who are uneducated have poor recording tools, which means that a health worker that wants to determine previous vaccination history in order to provide current vaccination services might not be able to do so, which might be a factor that could contribute somehow to immunization inequity. The last point regarding electronic immunization registry, I think I will answer, and as time permit, maybe William Kabore, who is on the line, I still believe could also say something. The latest information that I have is that the process had started. The process had started, but I think there was some consultation at the Ministry of Health to determine the operator, the who will do the work, etc. But as I said, this is not something you should jump into very quickly without proper planning, because there are some challenges with sustainability, deploying it into the whole country, etc. And I should also say that the country is confronted with insecurity in some part of the territory. So all those are challenges that may make electronic immunization not to be a real thing right now or in the near future. But if William is able to add something, that would be great. Over, Catherine.
Thank you so much. There's an echo coming from. Okay. There's a question on the presentation actually reflects the home-based records are not displaying recently introduced vaccines. This is the PCV, Rota, and measles, rubella. So how are these recorded and reconciled for continuity of a child's health history or status? And secondly, how are the missing vaccines recorded? And in the same vein, there's another question around how the vaccinators are responding to the changes in the vaccines and recording them. Did Burkina Faso face any resistance from the vaccinators? And if so, did they, how did the country deal with this? So that sounds like about 3 questions in one. Are you able to address those?
If you don't mind, can you repeat them quickly?
Okay. The first one is around the, like the home-based records are not exactly displaying the recently introduced vaccines, and they referred to the PCV, the Rota, and the MR. So now the question is, how are these recorded and reconciled for the continuity of the child's health history or status? And then how are the missing vaccines recorded? Then thirdly, the vaccinators are not responding to the change in vaccines and recording them. Did Burkina Faso face any resistance from the vaccinators? And if so, how did the country deal with this? So this sounds like a change management issue.
Mm-hmm. Okay. For the home-based records that fail to display some of the vaccines, which would clearly lead to challenges in tracing back or reconciling the history of vaccination of a given child. So the problem, I should remind the context of the study. It's like this study was done at the exit of first health facility. So it means that there are some children that have been vaccinated with some of those vaccines like PCV or Rota or MR2, but that information would not have been recorded, for instance, in the vaccination card. But the thing is, unless someone is interested in like doing a survey, like what we did, and then trying to find out what was the exact status of vaccination status of a given child, then the situation goes as such, it goes unaddressed, and that's why it's a problem. Before that study, we were conducting a PCV impact study, a carriers survey whereby we were taking nasopharyngeal swabs from children, and we wanted to, at the same time, determine their vaccination status vis-a-vis PCV so that we can analyze vaccine impact. But we were facing challenges in determining the vaccination status, so this is a real problem. One thing that we also found, but that I didn't show here, is that something like 6% of the children, it should be like 40 children, 40, could never be traced back in any of the registers that we looked at. Like, okay, you looked at information from the card, and because we wanted to capture information from both sources, you report to the immunization register, and then you were never able to retrieve that child. It means that that information is definitely lost. Whether there was some resistance to record the newly introduced vaccines, as far as I know, I wouldn't speak in terms of resistance to record those newly introduced vaccines, but to me, my perception of the situation is a lack of awareness of the importance of making sure that the information is properly captured. Maybe for the vaccinator, if you look to the card, PCV and rotavirus vaccine, the 3 series are given at the same time as pentavalent vaccine. So for some health workers, even if a card does not have pre-printed fields for PCV and Rota, but the card has pre-printed field for for pentavalent, because pentavalent is given at the same time as the other vaccine, they will just record information for pentavalent, and assuming that if the child received pentavalent, then the child also received the other vaccine that are administered concomitantly. But that's not be the case actually, because one vaccine might, for instance, be not available that day. So this is to say that I wouldn't put it in terms of resistance, but rather in terms of lack of awareness of the importance of rigorously documented vaccination status. Over.
Thank you so much.
Okay. Please, Catherine.
Yes?
I want some time to speak, but I don't know if it's possible to complete the answer of my colleague.
Yeah, sure. Yes.
You forgot me, I don't know why.
Okay, my dear. You can go ahead.
Thank you. For all the people, I am William Kabore. I'm from the EPI of Burkina Faso. So I conduct the study with my colleague, Lassane, who was at IMP. I want to say something before about the electronic registry, immunization registry. I think that it is a project in our plan, quality plan, but it's a problem of cost. It's very expensive. So I think that with one of the organization, the ONG, we want to begin this in few districts and before to scale up. But it is in project because it's very expensive. We assess the cost of the implementation, and I think that it's very expensive. So in the plan, we must begin in few districts before to extend. It's the same like the ICMI registry with the support of some partners. We began in a few districts and we have not scaled up at the moment because I think that the problem of cost is very important. To come back to the problem of the data quality, I think that is not a problem of the resistance because before all the introduction of new vaccine, we have many sensitization, we have many activities with the different health workers. So everyone is very involved, but it's the practice because the vaccination card, the home base is not updated, and the update is also a problem because the district and the health facility have to change and to finance. When the national EPI can't finance the new tools, we must the district and the health facility must to do the change at in the peripheral level. So it's according to me, it's the real problem, because when we introduce the ROTA and the PCV, we are not that vaccine. There's vaccine in the vaccination card. So when the health workers, the vaccinator, do all vaccination, they'll only put the date of the vaccine. It's a big problem. They don't take the time to add. We say them to add to write a ROTA with the pen and also PCV. But Lassane can say that for the other vaccine like meningitis A and the second dose of measles and rubella, we elaborate stamp. We give stamp to all the facilities before the vaccination, to begin with the meningitis. When we introduce the vaccine, we take the example of the study and begin to correct. I think that now we change all the tools. We have new register, we have a new vaccination card, but we say that all districts must take the responsibility, because the EPI introduction is it change every time. So they must also to take the initiative to change the support But for the big support like the registry is very difficult, and we don't we did it at the national level. Okay. Thank you.
Thank you. Thank you so much, William. That was very insightful, and I hope you've responded ably to the ones who asked those particular questions. And I saw there was something from one of the regional mentors who said there's actually an assessment tool that could be used. Now, very quickly, we can take in a couple of some more questions. There was a question relating, in fact, there were a couple of questions relating to the home-based records information. There was a question on how authentic is HBR information, and was there any recent data quality assessment for Burkina Faso which can help to assess data of these, data quality of these HBRs, and whether the recorded on HBR is really vaccinated, and what are the possible reasons for incomplete FBRs. Then related to that is another question on the discordance between the home-based records and the facility-based records. That they can also be related to outdated registries, such that some children start the vaccination at a point. They start the vaccination at a point but end it in another health facility. Did you consider the frequently visited health facilities by the caregivers during the assessment? Are you able to take in those ones? The first one is talking about the authenticity of home-based records, and whether there was any DQA undertaken in Burkina Faso to assess this, and whether they're really vaccinated, it's true or not. And are there any possible reasons for incompleteness of these? Then the other one is talking about the inconsistencies or the discordances between the two types of records. Did you consider the frequently visited health facilities by the caregivers during the assessment, given that some children start their vaccination at one point and end up at another health facility? Are you able to take in those?
Yes, Catherine. So for the first question, which asked about the authenticity of the home-based record, and yeah, if I understood well the question, I think the question is about the specificity of the home-based record, like even if the how to say, if the child might be false positively vaccinated according to the card, meaning that the health worker just mentioned, and then yeah. So I think this is another but related issue that we didn't really investigate in the context of the current study. I know that DQA has been and is still being conducted in some health districts. Whether they look to this particular aspect, I'm not sure. But I think for the sake of our analysis, we consider that if an information is mentioned on the card, which this really means that the child has been vaccinated. But I think it's a relevant point to look into. Possibly my colleague William could say something whether he knows about investigating the quality of data from home-based record, whether if the health worker says that a child is vaccinated, is really the child vaccinated. And the reasons for incomplete home-based record. So I didn't really understand because incomplete here may means two things. Either the card didn't have pre-printed items to capture the data, So the reason for that, as William just said, it hasn't been systematically or countrywide updated at the time of introduction. So clearly you would find some home-based record that would miss certain items. But I think the question could also allude to why did certain health workers not record information on the card after they have actually vaccinated the child. And I think I explained that somewhere in the presentation, that it's probably either the workload or the low awareness of the health worker who may be assuming that, okay, because PCV is given at the same time as Penta, there is no recording field for PCV, but there is a recording field for Penta. I will not give myself the pain to record twice or 3 times. I will just record for pentavalent. And then the assumption is here is that, okay, because those vaccines are given at the same time, if and when one sees that PCV is given, then one can imagine that the other vaccines that are concomitantly administered should have concomitantly been administered are also given. But this is a false assumption, as we all know. That was the first question. For the second question, this is also an interesting point that the person is raising. The fact that children that migrate from one health facility to the other, which is something very frequent, the information might be missing from the destination register. Yes, we have seen this problem. We have seen this problem, and I was saying that 6% of the children were not able to be traced back into the register where we did the assessment. Most of them were because the mother didn't start the vaccination there. Let's say the mother started in Bobo Dioulasso, which is the second largest city, which is like 300 kilometers away. And then the mother had, after delivery, the mother had traveled to the capital, so far away, and then goes to the immunization facility there. The tendency for healthcare workers is not to record that child in their own register, because they say, oh, the child didn't start here. The child started BCG or OPV elsewhere. So they call this child all zone, which means out of area. The child being coming out of catchment area, we will not put the child in our register. They are supposed to have an extra notebook that they call like extra area notebook, something, CAE or zone. But in actuality, this is not properly implemented. So that's why if we're able to implement an electronic immunization register, whereby each and every child has a unique ID, wherever the child is vaccinated in the country, when the same child report to a different health facility, when they integrate the system, they will find the vaccination status of that child. But until we do that, and the other problem is that the two health facilities will not communicate with each other. The destination health facility, after vaccinating the child, may record that information on the child card, but they will not report that information on their register. But at the same time, they will not call or send that information as a feedback to the first health facility. So that information is lost somewhere and not available to the health system. Over.
Thank you. William, did you want to
yes,
add?
okay, yes, I want to say something. Thank you to Lassane. But I want to, for the concordance in the register, I want to add the problem of when we vaccinate the children, we have also another tools, the feuille de, comment on appelle, we have a form for the all vaccination, we have a form, and the vaccinator use it form to record all the vaccination before to go to the register. Fiche de coche, we call in French fiche de coche. It's a form for the vaccination daily. Okay. Donc sometimes they don't report directly the same day at the same time all the vaccination. This is a reason, also one reason of the difference in the register. If you don't report at the same time, we also say the vaccinator to do the best to report after the vaccination. When the vaccination is finished, to report all the vaccination date for the different vaccine in the register at the same time. Sometimes you have some problem like that. But the problem of the out of area person is very important in our context, and we say the vaccinator to have the register for the out area infant and children, but it's very difficult. So if you record all the children, your error can be more. According to the DQA, I want to say that it's also all the quality assessment. We have some problem. It's the problem of the cost. At the past, we have regularly some budget for the DQS and the DQA, but since about 3 or 4 years, we have no financial support for this. So the district didn't conduct the validation session for all this. But in the plan, it's normal. Normally, you must to do an assessment for different source documents for the quality aspect every quarterly, every 3 months. But in the practice, it's very difficult. But many districts continue to do not the DQA, but the DQS, the data quality self-assessment. But some of them have some local financement, so some of them is with Gavi, but it's not all at the level. It's not for all the districts of the country. It's this problem. Thank you
very much, William. There are a couple of questions. There's one on how the recall bias is mitigated, and then there's one that is referring to the last figure. So maybe as you are talking about responding to the question on the recall bias, how it's mitigated, maybe I could just flip through the slides, share the slides to refer to the last question, which is talking about why the facility-based information is lower for percentage of the FICs, and if this is because of the movement between facilities. Can I just get into the presentation slide as you're answering the one on the recall bias?
Yes, yeah, you can do that.
Okay.
For the recall bias, so I think we did not try to address this bias as such, as this is something difficult to do. However, we wanted to see the impacts of recall on the estimation of coverage. So as you can see, even in this figure that Catherine just showed, you can see that if you add recall, then you gain something like 20 to 30% increase in your coverage estimation. Okay, so that was the thing we wanted to see, given that we were not sure that if, for instance, the mother says that the card says that the child was not vaccinated, let's say for PCV2, we were not sure that that was really the case. So we thought the mother could contribute to that information by asking her as well whether her child got that information, got that vaccination. But what we tried to do to minimize the recall bias in this case is limiting those. Is just limiting the recall to two vaccines, because the schedule is complex. As I said, there are up to 17 vaccine doses, so you can't imagine a mother, even an educated mother, to be able to recall all those vaccines. even sometimes health professionals are not able to remember the schedule. So we limited the recall to those two vaccines, rotavirus and PCV, for the reasons that we've explained. PCV was given as a second shot in the opposite thigh of the child during the vaccination. So usually during those days, the child would cry, the child would have some fever, and it's like a landmark. It's difficult for the mother not to remember the day that the child received two injections. So that's why we added a vaccine that was tied to an already existing vaccine that was PCV. That was pentavalent. So we tied PCV to pentavalent to try to give a clue for mothers to recall. And for rotavirus, that we also asked for the recall. As I said, it's because this usually in our setting, the way they administer rotavirus, in many instances, the vaccinator would give the vial to the mother and ask the mother to administer herself to the child. So because of this self-administered fashion of this vaccine, this might also be a clue for the mother to remember. So then we found that a study was supporting this theory. A study was indicating that visual clues could improve recall. Yeah, so that's why we also use those two vaccines. But as such, we did not address recall bias. It is what it is. So even the coverage that we can see here, what do you do with them? It's another question. And this question is actually related to the second one, which was asking why estimate by facility-based record wear is consistently lower than those of home-based records. Exactly. The reason, even before this figure, the other figure that we showed for individual antigens, you observe the same thing there. So it's certainly because, as I just said a few minutes ago, a sizable number of children were not even able to be traced back into those health facility registers probably because of the movement of your migration, etc. So you can imagine that all those situations whereby the child is not found in the register, you are not able to estimate or to determine coverage according to the register. So I think that those are part of the reasons why we found that HBR were doing better than FBR. But there was a recent meta-analysis that we cited in our paper that looked to the situation in low or middle income countries. I think this finding that HBR get higher coverage than FBR has been reported in that meta-analysis as well. We could follow up and I could provide details for that. But I think the situation in high income countries is the other way around. Facility-based records tend to be more sensitive in those settings than health facility-based than home-based records. Over.
Thank you so much, Lasane. Somebody has been complimenting you and they're saying this is a great paper, and we're wondering if you could actually share this paper via Science Direct, and so that it could be accessible to everyone, because I think the other links that were provided were not open for access from anywhere, and I'm sure they're talking about accessible to everybody. So they've provided a link which we'll be able to share with you, so that if it's possible, you could share the paper. Yeah, so that you could share the paper. And yes.
Because it wasn't open access. I think the publication wasn't open access. That's why it's not accessible. But I'm happy to find ways to make it accessible without violating the publication policies of the journal.
Thank you so much. Are there any other questions for the presenter? I think we still have like a couple of minutes. The lines are open. Anybody who ask a question? All right. If there aren't any other questions, I'd like to sincerely thank everyone who's participated in this webinar. You must have you've taken time from your busy schedules just to hear what this paper was all about, and it was very engaging. We'd like to thank everybody for your questions, and also I could see the chats, the science chats in the chat box there, and just to say thank you very much to our presenter, our speaker for today, Dr. Lassane Kabore. Thank you very much for this presentation. Very, very enlightening. And enlightening, and thank you so much to the co-authors like Dr. William Kabore, who came in also to provide more insights into what the study was all about and the clarifications. And we'll just like to let everyone know that if you missed part of of today's presentation, or basically just weren't able to attend the webinar, this webinar has been recorded, so we will be able to share the recording and the slides via the BLN website. And we hope to keep everybody engaged in the discussion. Please feel free, if you've got any questions or clarifications for the speaker and the co-authors, I'm sure they'll readily be available to respond to them. So having said that, thank you so much, everybody. A big thank you to all of you. And we encourage you to stay safe from the COVID-19 until the next webinar, which is scheduled for next week, Thursday. So look out for the next invitation, because this one will actually be talking about the DIHS2 app, applications for data use culture. So bye for now.
Bye, until next time. Thanks.
Bye-bye. Thank you so much, Lassane. Thank you so much, William. Thank you, everybody.
Thank you. Thank you. Bye-bye.